Okay, now let us start with chapter 60 of your Apurba Sastry Essentials of Microbiology, which is about bacterial pharyngitis. In this chapter, we will be previewing streptococcal pharyngitis, diphtheria, and rare causes of bacterial pharyngitis. Introduction. Pharyngitis or sore throat is one of the most common upper respiratory tract infection. Viral pharyngitis accounts for vast majority of cases and is usually self-limited. Bacteria are also important etiologic agents of pharyngitis, require specific antibiotic treatment, if not given can lead to serious complications and sequelae. The common etiological agents of bacterial pharyngitis include Streptococcus pyogenes, most common, Corynebacterium diphtheria, and other rare causes include other beta hemolytic streptococci like group C and G, Arcanobacterium hemolyticum, Fusobacterium necrophorum, Mycoplasma pneumoniae, and Neisseria gonorrhoeae. Now, starting with streptococcal pharyngitis. Streptococcus pyogenes or group A streptococcus is the most common bacterial cause of pharyngitis in children and accounts for 5 to 15% of all sore throats in adults. Infection occurs through respiratory droplets. In addition, it causes skin and soft tissue infection. Clinical manifestation. Streptococcal sore throat presents as either localized tonsillitis or diffused pharyngitis. Symptoms manifest as erythema and swelling of pharyngeal mucosa with purulent exudate formation. Younger children less than 3 years present with a syndrome of fever, malaise, lymphadenopathy without exudative pharyngitis. Suppurative complications may occur due to direct extension of infection from pharynx to deeper tissues, causing peritonsillar abscess or quinsy and retropharyngeal abscess. Or second, very rarely downward spread to the respiratory tract causing pneumonia or empyema. And third, hematogenous spread leading to bacteremia and meningitis. In this figure, we can see streptococcal sore throat with enlarged tonsils covered with white fibrous exudate. Non-suppurative complications may develop 2 to 3 weeks following streptococcal sore throat mediated by autoimmune mechanism. ARF, acute rheumatic fever, is the most common non-suppurative complication developed following streptococcal pharyngitis. It involves cardiac valves, joints, and other sites. PSGN, post-streptococcal glomerulonephritis, is another sequelae that usually develops following streptococcal pyoderma but can rarely occur following streptococcal sore throat. Differential diagnosis of streptococcal sore throat include diphtheria. It can be differentiated from streptococcal pharyngitis by presence of membrane over the tonsil. Viral pharyngitis is differentiated from streptococcal pharyngitis by presence of concomitant rhinorrhea, oral ulcers, cough, and or hoarseness. Scarlet fever is mediated by streptococcal pyrogenic exotoxin SPA, B, and C. It is characterized by pharyngitis and rashes with sandpaper feel, strawberry tongue, enlarged papillae or on a coated tongue. Rashes in the skin folds are called as Pistia's lines. Scarlet fever has become less common now, although strains producing SPE continue to be prevalent in the community. Reasons are not clear. Lab diagnosis. Culture. Throat oropharyngeal swabs should be collected by vigorous rubbing of a sterile cotton swab over both tonsillar pillars. 2 swabs may be collected, one for direct smear and other for the culture. Culture on blood agar streptococcus pyogenes forms small pinpoint colonies of 0.5 to 1 mm size with a wide zone of beta hemolysis. Culture smear gram stain smear from the colonies shows gram-positive spherical cocci 0.5 to 1 micrometer arranged in short chains. Identification. Streptococcus pyogenes is identified by conventional biochemical test, catalase negative and susceptible to bacteriacin, or by automated infection systems such as MALDI-TOF or VITEC. Rapid antigen detection test RADT. RADT is available commercially, which detects group A carbohydrate antigen from throat swab by latex agglutination or enzyme immunoassay for the diagnosis of pharyngitis. As it is a highly specific, more than 95%, a positive result can be relied upon for definitive diagnosis and eliminates the need for throat culture. However, the sensitivity of this test is variable 55 to 90%. Therefore, a negative result should always be confirmed by throat culture. ASO titer. Anti-streptolysin O ASO antibodies appear late. Therefore, a retrospective diagnosis of streptococcal infection may be established by detecting ASO antibodies in patient serum. This may be useful for establishing rheumatic fever. Molecular test. Commercial PCR assays available for the detection of Streptococcus pyogenes in throat swab. It is a rapid point of care test, turnaround time of 15 minutes, claims to be more sensitive than antigen detection tests, and therefore, if it is negative, eliminates the need for culture. Treatment for streptococcal pharyngitis. For pharyngitis, benzathine penicillin G, IM single dose or oral penicillin V for 10 days is recommended. For recurrent pharyngitis, clindamycin or amoxicillin calavulinate is recommended. For concomitant pneumonia and empyema, penicillin G plus drainage of empyema is recommended. Now coming on to diphtheria. Introduction. Diphtheria is a highly infectious childhood disease caused by bacterium Corynebacterium diphtheriae, which primarily infects the throat and produces toxin, diphtheria toxin, that causes an exudative pharyngitis and membranous tonsillitis. If not promptly treated, it can be life-threatening. The genus Corynebacterium is a gram-positive, non-capsulated, non-sporing, non-motile bacillus. It is irregularly stained and frequently shows club-shaped swellings. Greek word corny means club. It has several species, the most important pathogenic species being Clostridium diphtheriae. The other Corynebacterium species, it's not Clostridium diphtheriae, it's Corynebacterium diphtheriae. The other Corynebacterium species, called as diphtheroids, are usually found as common cells of throat and skin in man, can occasionally cause infections. Corynebacterium diphtheriae typically shows two characteristic features which differentiates it from other Corynebacterium species. In these figures, we can see Corynebacterium diphtheriae. In figure A, club-shaped bacilli in methylene blue stain smear. In B, gram stain smear shows V or L-shaped bacilli with cuneiform arrangement. And in C, we can see Albert stain, which shows dark blue metachromatic granules at the end of green bacilli. Okay. Now, the two features are Chinese letter or cuneiform arrangement. They appear as V or L-shaped in smear because the bacterial cells divide and daughter cells tend to lie at the acute angles to each other. This type of cell division is called as snapping type of division. And metachromatic granules, they are present at the ends or poles of the bacilli. Metachromatic granules, also called as polar bodies or Baby's Ernst bodies or volutine granules, they are storage granules of organism composed of polymetaphosphates. Granules are stained strongly gram-positive compared to the remaining part of the bacilli. The granules take a bluish-purple metachromatic color when stained with Loeffler's methylene blue. However, they are better stained with special stains such as Albert's, Neisser's and Ponder's stain. Granules are well developed on enriched media such as blood agar or Loeffler serum slope. Volutine granules can also be possessed by other organisms such as Corynebacterium xerosis and Gardnerella vaginalis. Now coming to history, diphtheria is an ancient disease known since the time of Hippocrates. Diphtheria was first recognized by Pierre Bretonneau in 1826. He used the term diphthery, Greek word diphtheros, meaning leather-like, to describe the characteristic manifestation, that is leathery pseudomembrane formation over the tonsil. Clostridium Corynebacterium diphtheriae was first observed by Klebs and first cultivated by Loeffler. Hence it is known as Klebs-Loeffler bacillus. Virulence factor, diphtheria toxin. Diphtheria toxin DT is the primary virulence factor responsible for diphtheria. Toxin is a polypeptide chain comprises of two fragments, A active and B binding. Fragment B binds to the host cell receptors such as epidermal growth factor and helps in entry of fragment A. Fragment A gets internalized into the cell and then acts via the mechanism given below. Mechanism of diphtheria toxin DT. Fragment A is the active fragment which causes ATP ribosylation of elongation factor 2 EF2. It leads to inhibition of EF2, which leads to inhibition of translation step of protein synthesis. Exotoxin A of Pseudomonas has similar mechanism like that of DT. Now, factors regulating the toxin production. The production of diphtheria toxin is dependent on various factors. Phage coded. DT is coded by bacteriophages called as beta corniphage carrying tox gene. Corynebacterium diphtheriae remains toxigenic as long as the phages are present inside the bacilli lysogenic conversion. Iron concentration. The toxin production depends upon the optimum concentration of iron 0.1 mg per titer. Other species DT is also produced by Corynebacterium ulcerans and Corynebacterium pseudotuberculosis. toxoid is used for vaccination. Diphtheria toxin is antigenic and antitoxins are protective in nature. However, as it is virulent, it cannot be given directly for vaccination. Toxin can be converted into toxoid, which can be used for vaccination. Toxoid is a form of toxin where the virulence is lost, retaining the antigenicity. Toxoid formation is promoted by formalin, acidic pH, and prolonged storage. Mark William 8 strain of Corynebacterium diphtheria is used as a source of toxin for the preparation of vaccine. LF unit dt is expressed as limit of flocculation LF unit. 1 LF unit is the amount of toxin which flocculates most rapidly with 1 unit of antitoxin. Pathogenicity of and clinical manifestation. Pathogenesis of diphtheria toxin is toxin mediated. Diphtheria is toxemia but never a bacteremia. Bacilli are non-invasive, present only at the local site pharynx, secrete the toxin which spreads via bloodstream to various organs. It is the toxin which is responsible for all types of manifestation including local, respiratory and systemic complications, except the skin lesion which is caused due to the organism, not toxin. Respiratory diphtheria is the most common form of diphtheria. Tonsil and pharynx. Facial diphtheria are the most common sites, followed by nose and larynx. Incubation period is about 3 to 4 days. Facial diphtheria toxin elicits an inflammatory response that leads to necrosis of the epithelium and exudate formation. This leads to formation of mucosal ulcers lined by a tough, leathery, grayish-white pseudomembrane coat composed of an inner band of fibrin surrounded by neutrophils, RBCs, and bacteria. It is so named as it is adherent to the mucosal base and bleeds on removal, in contrast to the true membrane which can easily be separated. In this figure, we can see the pseudomembrane covering the tonsils, characteristically seen in diphtheria, and the bull neck appearance seen in diphtheria as well. Extension of pseudomembrane. In severe cases, it may extend to the larynx and bronchial airways, which may result in fatal airway obstruction leading to asphyxia. This mandates immediate tracheostomy. Bull neck appearance is characterized by massive tonsillar swelling and neck edema. Patients present with foul breath, thick speech, and stridor, which is noisy breathing. Cutaneous diphtheria. It presents as punched out ulcerative lesions with necrosis or rarely pseudomembrane formation. Most commonly occurs on the extremities. Cutaneous diphtheria is due to the organism itself and is non-toxin mediated. Hence, it is possible that the skin lesions may also be caused by non-toxigenic strains. There is increasing trend of cutaneous diphtheria nowadays, especially in vaccinated children, because antitoxin present in the vaccinated people cannot prevent the disease. Systemic complication. Polyneuropathy and myocarditis are the late toxic manifestation of diphtheria occurring after weeks of infection. Other complications of diphtheria include pneumonia, renal failure, encephalitis, cerebral infarction, and pulmonary embolism. Neurologic manifestation. It is a toxin-mediated non-inflammatory demyelinating disorder presented with cranial nerve involvement, peripheral neuropathy, and ciliary paralysis. Myocarditis is typically associated with arrhythmias and dilated cardiomyopathy. Now coming to the lab diagnosis, isolation of Corynebacterium diphtheria specimen, throat swab and a portion of pseudomembrane is taken. Direct smear, gram stain, club-shaped gram-positive bacilla with Chinese letter arrangement and an Albert stain green bacilla with bluish-black metachromatic granules are present. Culture media, enriched medium, blood agar, chocolate agar and Loeffler serum slope. Selective medium, potassium telluride agar and tinsodale medium produces black colonies. Identification biochemical tests such as sugar fermentation test during his serum, sugar media, and automated identification systems such as Malditoff and Vitek. Diphtheria toxin demonstration and in vivo test, guinea pig inoculation, subcutaneous and intracutaneous test. In vitro test, ELS gel precipitation test, detection of tox gene by PCR, detection of toxin by ELISA or ICT, and cytotoxicity on cell lines. Lab diagnosis. The diagnosis of diphtheria is based on the clinical signs and symptoms plus laboratory confirmation. Because of the risk of respiratory obstruction, specific treatment should be instituted immediately on clinical suspicion without waiting for the lab reports. Lab diagnosis is necessary only for confirmation of the clinical diagnosis, initiating the control measures and epidemiological purposes. Lab diagnosis consists of isolation of the bacilli and toxin demonstration. Isolation of diphtheria bacilli specimen. Useful specimens include throat swab 1 or 2 containing fibrinous exudates, a portion of pseudomembrane, and nose or skin specimens if infected. Direct smear microscopy, gram stain Corynebacterium diphtheria appear as irregularly stained club-shaped gram-positive bacilli of 3 to 6 micrometer length, typically arranged in Chinese letter or cuneiform arrangement V or L shape. It is difficult to differentiate them from other commensal corniforms found in the respiratory tract. Albert stain is the most specific for Corynebacterium diphtheria. They appear as green bacilli with bluish black metachromatic granules at the poles. Details of Albert staining are given in chapter. Culture media. Enriched medium. Corynebacterium diphtheria is fastidious, aerobe, and facultative anaerobe. Does not grow on ordinary media. It grows best in enriched mediums such as blood agar, chocolate agar, and Loeffler serum slope. Plates are incubated at 37 degrees Celsius aerobically. Blood agar colonies are small, circular, white, and sometimes hemolytic mitis biotype. Loeffler serum slope colonies appear as small, circular, glistening, and white with a yellow tinge in 6 to 8 hours. Advantages: growth can be detected as early as 6 to 8 hours. Best medium for metachromatic granule production. Disadvantages: being an enriched medium, if the incubated beyond 6 to 8 hours, it supports the growth of other throat commensals also. Selective medium. Selective media are the best for isolation of Corynebacterium diphtheria from the cases as well as from carriers, as normal flora will be inhibited. Potassium telluride agar PTA Corynebacterium diphtheria reduces telluride to metallic tellurium, which gets incorporated into the colonies, giving them black color. Corynebacterium ulcerans and pseudotuberculosis can also grow on PTA, producing black colored colonies. Advantage: throat commensals are inhibited. Disadvantage: colonies appear only after 48 hours of incubation. Identification: species identification of Corynebacterium diphtheria is made by biochemical tests such as sugar fermentation test by using his serum, sugar media, and pyrazinamidase test and third urease test. The latter two tests are negative for Corynebacterium diphtheria. In this figure, we can see Loeffler serum slope in A and potassium telluride agar showing black colonies of Corynebacterium diphtheria in B. Automated identification systems such as Mylitov and Vitek of course can be used. Toxin demonstration: as the pathogenesis is due to the diphtheria toxin, mere isolation of bacilli does not complete the diagnosis. Toxin demonstration should be done following isolation, which can be performed by in vivo and in vitro methods. In vivo test: animal inoculation. In vivo toxin demonstration can be done by inoculation of culture broth into guinea pig. With the advent of other techniques, this method is rarely followed nowadays. In vitro test: Elk's gel precipitation test is a type of immunodiffusion in gel described by Elk. The strain isolated is streaked onto a media containing a filter paper soaked with antitoxin. If the strain is toxigenic, it liberates the toxin, which diffuses in the agar and meets with the antitoxin to produce an arrow-shaped precipitation band. This test can also be used to know the relatedness between the strains isolated during an outbreak. The precipitate bands of outbreak isolate streaked adjacent. When meet with each other, three patterns may be observed. Cross over with each other, it indicates unrelated strain. Spur formation indicates partially related strain, and fuse with each other indicates identical strain. Other in vitro tests include detection of tox gene by PCR, detection of diphtheria toxin by ELISA or immunochromatographic test, and cytotoxicity produced on cell lines. In this Elk's gel precipitation test, we can see the crossover of bands, spur formation and fusion of bands is placed on horse serum agar plate. Isolates 1 to 4 toxinic strains as precipitation bands are formed due to binding of toxin produced by the strains with antitoxin released by the filter paper. Isolates 1 and 2, the precipitation bands crossed over indicate the toxin are not identical and therefore strains are unrelated. Isolate 2 and 3, there is partial fusion of precipitation bands indicates the toxins are partially identical and therefore strains are partially related to each other. Isolates 3 and 4, precipitation bands fused with each other indicate toxins are identical to each other and therefore strains are completely related. And isolate 5 is a non-toxigenic strain, no precipitation band is formed. Other in vitro tests we have discussed: the detection of toxin by PCR, detection of diphtheria toxin by ELISA immunochromatographic test, and cytotoxicity produced on cell lines. Now, the typing of Corynebacterium diphtheria. Typing methods are useful for epidemiological studies to know the relatedness between the isolates. Biotyping was used in past, based on which there are 4 biotypes of Corynebacterium diphtheria: gravis, intermedius, mitis, and Belfanti. They vary in virulence and toxin production, gravis being 100% toxigenic and more virulent. Epidemiology. Worldwide, there is declining trend of diphtheria cases in most countries, including India, due to widespread vaccination coverage. Source of infection: carriers 95%, the most common source of infection, than the cases 5%. Carriers may be temporary, persist for a month, or chronic, persist for a year or more. Nasal carriers are more dangerous due to frequent shedding than throat carriers. Incidence of carrier rate varies from 0.1 to 5%. Transmission is via the respiratory droplets, coughing, sneezing, or rarely by contact with infected skin lesions. Reservoir human are the only reservoir. Age diphtheria is more common in children aged 1 to 5 years with widespread immunization. A shift in the age has been observed from preschool to school age. Newborns are usually protected due to maternal antibodies. Situation in the world: due to widespread immunization, cases were drastically declined by 95% over the last 3 decades. However, there is a global resurgence of the diphtheria in recent years. 16,648 cases were reported in 2018. Russian epidemic. An epidemic of adult diphtheria occurred in Russia during 1990-97 with more than 1.1 lakh cases and 3,000 deaths. It was controlled by improved vaccination of children and adults. Situation in India. India still accounts for the highest burden. 60 to 70% of the diphtheria cases in the world. 8788 cases were reported in 2018. Resurgence of diphtheria in recent years is a public health problem in India. In 2019, outbreaks have been reported from Tamil Nadu, Kerala, Karnataka, and few other states. Majority, more than 70% of the cases are from children 5 to 10 years or more, which explains low coverage of diphtheria vaccine, especially the booster dose, as the primary cause of its resurgence. Waning immunity in adults may be a minor cause which contributes to adult diphtheria cases. Treatment should be started immediately on clinical suspicion. Anti-diphtheritic serum or ADS. Antitoxin passive immunization with anti-diphtheritic horse serum is the treatment of choice as it neutralizes the toxin. A test dose should be given to check for hypersensitivity. It is given either IM or IV, and the dose depends on stage of illness. Early stage less than 48 hours, 20 to 40,000 units. If pharyngeal membrane present, 40 to 60,000 units, and later stage more than 3 days with bull neck, 80 to 120,000 units. Human antitoxin therapy is under development. Antibiotics, penicillin or erythromycin is the drug of choice. Antibiotic plays a minor role as it is of no use once the toxin is secreted. However, antibiotics are useful if given early, less than 6 hours of infection before the toxin release. Prevent further release of toxin by killing the bacilli. Treatment of cutaneous diphtheria and treatment of carriers. Drug of choice is erythromycin. Disease is typically no longer contagious after 48 hours of therapy. Elimination of organism should be documented by 2 consecutive negative cultures after the therapy is completed. Prophylaxis. Infection control measures. Patients should be placed in isolation room and all the steps of droplet precaution should be followed for the prevention of transmission of Corynebacterium diphtheria in the hospitals. Post-exposure prophylaxis for close contacts, example household or booster dose of diphtheria vaccine plus penicillin G single dose or erythromycin 7 to 10 days is recommended. Vaccination. Diphtheria toxoid is useful for vaccination as it induces antitoxin production in the body. A protective titer of more than 0.01 unit per ml of antitoxin can prevent all forms of diphtheria. However, vaccine is not effective for prevention of cutaneous diphtheria, elimination of carrier state. Types of vaccine. Single vaccine. Diphtheria toxoid DT is prepared by incubating toxin with formalin and then the toxoid is adsorbed to alum. Alum acts as adjuvant and increases the immunogenicity of the toxoid. Combined vaccine. Various vaccines available are DPT contains DT diphtheria toxoid, pertussis whole cell and TT tetanus toxoid. Pertussis component acts as adjuvant and increases the immunogenicity of the DT and TT. DAPT contains DT, TT and acellular pertussis. TD contains tetanus toxoid and adult dose 2 LF of diphtheria toxoid, and pentavalent vaccine DPT can also be given along with hepatitis B and Haemophilus influenzae type B. Administration of diphtheria vaccine. Schedule under National Immunization Schedule NIS of India 2020. Children total 7 doses are given. 3 doses of pentavalent vaccine at 6, 10, 14 weeks of birth followed by two booster doses of DPT at 16 to 24 months and 5 years, and another two booster doses of TD at 10 and 16 years. Pregnant women should receive the two doses of TD at 1 month interval. The introduction of TD boosters in place of TT at 10 and 16 years and also in pregnancy is an attempt made to reduce the resurgence of diphtheria in adults. Side DPT is given deep intramuscularly at anterolateral aspect of thigh. Gluteal region is not preferred as fat may inhibit DPT absorption. Thiomersal 0.01% is used as preservative. Storage DPT should be kept at 22 to 8 degrees Celsius. If accidentally frozen, then it has to be discarded. The usual dose given to children of diphtheria toxoid contains 25 LF units, whereas the adult dose contains 2 LF units. Two commercial preparation of DPT are available. One dose 0.5 ml of vaccine contains Glaxo 25 LFDT, 5 LFTT, and 20,000 million pertussis killed bacilli. Kasoli 30 LFDT, 10 LFTT, and 32,000 million pertussis killed bacilli. Protective titer following vaccination or antitoxin titer of more than 0.01 international units per ml is said to be protective. Adult immunization. As adult diphtheria cases are increasingly being reported, adult immunization by TD vaccine has been recommended. Adults more than 18 years who have completed primary vaccination, TD booster doses indicated every 10 years till 65 years. Adults more than 18 years who have not completed primary vaccination, 3 doses of TD given at 0, 1 month and 1 year. Adverse reaction following DPT administration. Mild fever and local reaction, swelling and indurations are observed commonly. Severe whole cell killed vaccine of Bordetella pertussis is encephalitogenenic. It is associated with neurological complication, which is more common in children more than 7 years of age. In contrast, acellular pertussis is not associated with neurological symptoms. Therefore, for children more than 7 years of age who have not received primary vaccination, DAPT comprising acellular pertussis vaccine is recommended. Absolute contraindication of DPT include hypersensitivity to previous dose and progressive neurological disorder. Schick test is a toxin antitoxin utilization test was used long back to test the susceptibility of the individual to diphtheria before starting immunization. It is obsolete now. Diphtheroids or corniforms are the non-diphtherial corny bacteria that usually exist as normal commensals in the throat, skin, conjunctiva, and other areas. However, they have been associated with invasive disease, particularly in immunocompromised patients. They can be differentiated from Corynebacterium diphtheriae by many features such as stains more uniformly than Corynebacterium diphtheriae, palisade arrangement arranged in parallel rows than cuneiform pattern, and absence of metachromatic granules, except for Corynebacterium xerosis. Corniforms that are rarely pathogenic to man are clinically resembling diphtheria, Corynebacterium ulcerans and Corynebacterium pseudotuberculosis produce diphtheria toxin and cause localized ulcerations in the throat, clinically resembling diphtheria. Corynebacterium ulcerans causes infection in cows. Human infection may occur through cow's milk. Corynebacterium pseudotuberculosis pre-Nocardium bacillus causes pseudotuberculosis in sheep and suppurative lymphadenitis in horses. Human infection is very rare. Corynebacterium minutissimum causes a localized infection of skin, axilla and groin caused as erythrasma or Wood's lamp examination. Erythrasma lesions emit coral red color. Okay. Now in this figure we can see diphtheroids which have a palisade arrangement of gram-positive bacilli. Corynebacterium jejicium is lipophilic species. Colonized skin of hospitalized patients can cause bacteremia, endocarditis, meningitis, especially in immunocompromised hosts. It is usually multidrug resistant, responds only to vancomycin. Corynebacterium uriolyticum is skin commensal, rarely causes urinary tract infection, pyelonephritis, and alkaline encrusted cystitis. Struvite stones in alkaline urine in immunocompromised patients and renal transplant recipients. Corynebacterium diphtheriticum is known as common cold in throat. However, immunocompromised patient, it can cause exudative pharyngitis, may mimic respiratory diphtheria and endocarditis. Corynebacterium parvum is frequently used as immunomodulator. Rare cause of bacterial pharyngitis, gonococcal pharyngitis. Neisseria gonorrhoeae is sexually transmitted bacterium. Commonly causes urethritis. Rarely can cause pharyngitis following transmission by orogenital sexual contact. Diagnosis: nucleic acid amplification test and ability of the throat swab targeting Neisseria gonorrhoeae is the test of choice. However, it may be false positive owing to the presence of common cell Neisseria species in the oropharynx and therefore should always be confirmed by nature. Treatment: ceftriaxone plus azithromycin is the regime of choice. Other rare causes of bacterial pharyngitis include other beta hemolytic Streptococcus group C and G, Arcanobacterium hemolyticum, which was formerly placed under Corynebacterium. It can cause pharyngitis and skin ulcers. It is beta hemolytic, produces a positive reverse CAM test. Azithromycin is given for treatment. Fusobacterium necrophorum is an anaerobic gram-negative spindle-shaped bacillus, rarely cause pharyngitis. Mycoplasma pneumonia is usually caused atypical pneumonia, which can also be associated with pharyngitis. Pharyngitis can be prime infestation of various other sexually transmitted infections like herpes, HIV/AIDS, rarely secondary syphilis. Now we come to the expected questions. An essay on a child aged 7 years, high grade fever, toxic pain, throat, inability to swallow was brought to the casualty examination. White patch was found on the fauces, which started bleeding when touched. No history of immunization is available. It's a case of diphtheria, clinical diagnosis, radiological agent, and detail of pathogenesis, lab diagnosis, and management we can try it. Now, short note on DPT vaccine or streptococcal pharyngitis also we can do. Now coming on to production of early metachromatic granules can be seen best in which of the following media? It is first question. Uh, in this we can see the nutrient agar, chocolate agar, Loeffler serum slope and potassium telluride agar. So metachromatic granules are best seen in Loeffler serum slope. Which of the following is the most common affected site by Clostridium diphtheriae? It is most commonly is the faucial diphtheria which happens. Okay. Now, metachromatic granules of Corynebacterium diphtheriae can be stained by all of the following special stains except it can be stained by Neisser's, Albert's and Ponders but not the Zn stain. Diphtheria toxin is produced by all except Clostridium diphtheria, yes. Clostridium ulcerans, yes. Pseudotuberculosis, yes. Cirrhosis, no. Scarlet fever is caused by Streptococcus pyogenes. So this completes our chapter. Next we'll be starting with bacterial lobar pneumonia. Okay, so like, share, subscribe. Thanks for watching.